Okay. Oh, it's only 29 minutes past. Otherwise, half past. We'll get started on today's session. My name is Nick Medland. I'm the president of ASHM, the Australian Society of HIV, Sexual Health and Viral Hepatitis Medicine, and we're running this conference, this terrific conference that I'm sure you've all enjoyed. Some housekeeping. The exhibition hall will be closing at 4:30 p.m. No one will be allowed access unless you're an exhibitor. You must remove anything you've included, including posters you'd like to keep by 4:20 p.m. Everyone has access to the virtual portal where you'll be able to watch any sessions you've missed during the conference. PDFs of the posters are also available for those who provided them, from those who have provided them. You can access the portal via the link you were sent in your final confirmation email, and the content will be available for 3 months. So welcome all to this session on HIV and people who inject drugs. And welcome also to the people online. We've got 3 presentations of 20 minutes each. We're going to hold the discussion for the panel, who are all here in person afterwards, and we'll be taking questions online as well. I'll hand over to my co-chair.
Hi, welcome. My name's Erica Peters. I'm one of the infectious diseases consultants here in Glasgow. So I think we'll move straight on to this. Our first speaker today is Vanna Sipsa. Vanna is an associate professor in the National, and I have to say I'm not going to pronounce your university properly, title, in Athens, in Greece. She's a principal investigator in major community-based programs for people who inject drugs in Greece, and has contributed to the preparation of the national hepatitis C and HIV plans. So, Vanna, thank you. Let's hear what you have to say about this really interesting subject. I know you've published quite a lot on it. Thank you.
Thank you very much. These are my disclosures. So I guess all the people in this room, not so many people, but anyway, we all know that people who inject drugs are a key population not just for hepatitis C infection, but also for HIV. They have a much higher risk of acquiring HIV infection compared to the general population. And we know also that around 18% of people who inject drugs globally are living with HIV, which translates to around 3 million people with a lot of variation from region to region. Within this vulnerable population, there are specific subgroups who are particularly vulnerable. For example, racial and ethnic minorities. They have a higher risk of HIV infection, and this seems to be more pronounced in the US. And also in some countries, women who inject drugs have a higher prevalence as compared to men, perhaps because they have also a sexual risk of acquiring HIV. So HIV outbreaks date back to the beginning of the HIV epidemic. The first outbreaks spread within the population. HIV spread very extensively. Almost half of the population of people who inject drugs in cities like New York or Amsterdam or Edinburgh were infected. And after these initial outbreaks, more were recorded in other countries and other cities in Canada, Vancouver, or in countries in Eastern Europe or Central Asia. And all these outbreaks, the experience from these outbreaks led to introducing and scaling up interventions in order to stop transmission or reduce transmission. And since many, many years now, we know that high coverage combination interventions work and reduce the risk of acquiring HIV among people who inject drugs. So testing for HIV, linkage to antiretroviral treatment for patients, linkage to opioid agonist treatment, and distribution of needles and syringes. So it would be nice if I could stop here and say, so we know the solution and everything is also the end of my presentation. However, it seems that in the past few years, there is a series of multiple outbreaks, and in high-income countries, which is even more strange. So in 2011, we had 2 outbreaks recorded in Athens, Greece, and Bucharest, Romania. And I don't think people were very much surprised by seeing outbreaks in these 2 places, because Athens had a very low coverage of harm reduction programs. In Bucharest, there was reduction or termination of the global fund, so there was a scale down of harm reduction services. So I guess nobody was very much surprised. But a year later, we've seen increased transmission in Tel Aviv, Israel, then in Luxembourg, then in Dublin, and also in a rural area of Indiana and Scott County in North America. in US. We've seen also an outbreak in 2015 in Glasgow and in Massachusetts, and then in Canada, Ohio, and also in several counties in multiple states in US. So it's like, like a fire spreading all over the world. So a few years ago, we formed a group, the people who were involved in studying or responding to these outbreaks in Europe and North America, and we tried to discuss and see what was common and what was perhaps different in these outbreaks. What we have most sites, the outbreak sites, have seen is that homeless people were the ones who were affected in the beginning of these outbreaks. We have seen also that there were community economic problems in several of the sites, that in some of the sites there was limited prevention at the time preceding the outbreak, and also we have seen changes in injection practices and in particular in the main substance used. Concerning homelessness, I think it's such a consistent finding in all sites that's really something that we really have to take into account. And there was a recent meta-analysis showing that people who inject drugs and are homeless have 50% higher risk of getting HIV infected as compared to other people who inject drugs who have stable housing. Concerning community economic problems, I couldn't resist not showing the example of Greece because it was very famous at the time, not in a good way famous. We had this economic recession, the International Monetary Fund, austerity measures, and you can see that solid line is a decline in the rate of change of the gross domestic product. The blue bars show the rate of HIV diagnosis, and these triangles are actually the phylogenetic clusters from phylogenetic analysis from HIV sequences collected from people who inject drugs. And the beginning of this cluster show that this cluster, let's say, transmission occurred around the period of the economic recession. Of course, it does not show a cause and an effect, but I guess it's a coincidence that we cannot ignore. Concerning the fact that in some sites there were high coverage of prevention services, that seemed a little bit strange, but if we take a closer look, we will see that when there is a high coverage, the outbreak size is much more limited. Using the data from that recent review we had done on these sites, you can see this graph, three, let's say, levels of harm reduction coverage, no or low coverage, medium and high. And on the y-axis, you can see the number of cases reported in the peak outbreak years, adjusted also for the population size of people who inject drugs, because if you have a large population, you're going to see a large number of cases. And you can see that Athens and Scott County in Indiana had experienced much larger outbreaks as compared to their population, as compared, for example, to Glasgow and Dublin. Of course, this is not a 100% correct graph because a number of diagnoses depends on the levels of testing in each site. In Greece, we tested a lot during that time, and maybe it's a little bit unfair for us to be so high in this graph, but at least I think it gives us a sense of what was going on. In most sites, we have seen also a switch to drugs with shorter effect duration. We have seen, for example, you can see all kinds of changes, Bucharest and Tel Aviv. In Glasgow and Luxembourg, we have seen a change to cocaine use. In US, we had this introduction of fentanyl. I think the only place where there was no change in substance, the main, let's say, substance used for injection was Athens, although we had some reports about a new methamphetamine called shisha, but that was not that much used by the population. Another point I want to add is that in some cases, at least when we had data, there were low levels of HIV testing before the outbreaks. For example, the data for Glasgow show that before the outbreak in Glasgow city center, only 30% of people who inject drugs reported an HIV test in the past 12 months. And this is true also for Athens, and I guess for many other of the sites, but maybe they haven't published something about it. And another warning sign was that there were high rates of hepatitis C infection preceding the outbreaks, and there are reports also for Athens, and also in other places in the US. So how did we respond to the outbreaks? In that, you see that all the sites that participated in that review, everybody did almost the same things. You know, we increased testing and linkage to antiretroviral treatment. We increased access to OAT and NSP. I think we did all the things that we should have done a bit earlier, or increased, let's say, the coverage. But I want to present some examples where we try to apply some innovations. Starting from Athens, Greece, okay, we tried to scale up NSP and OET. That wasn't hard because we were very low in the beginning. We tried to scale up HIV testing also, but we needed to apply something innovative because we were in the middle of an ongoing outbreak, and we wanted to do something that was really more, let's say, radical. We wanted to reach those people who were most at risk, not the people who were linked to services, but we wanted to reach migrants without documents, and we had a lot of migrants at that time. We wanted to achieve a high coverage, not just test some people in a few days, and we wanted to do this very rapidly because we had this outbreak. So we designed this program, a seek, test, treat intervention that focused on rapidly identifying people who inject drugs, offer testing, counseling, and linkage to HIV care, linkage to OET, distribution of syringes. So there were many components in this program. That was implemented in the center of Athens in a community, let's say, based location. And for recruitment, we used responder-driven sampling, where people, recruit people from their own injection networks. And what was, let's say, more innovative in our approach is that we performed multiple RDS recruitment rounds, which means that we recruited 1,400 people using RDS, we stopped recruitment and then started again, and we did that 5 times because it had many advantages. I will show you if I have some time. So you see the participants in each recruitment round. So in a few weeks, we were able to recruit 1,400 people. And the second round, again, some of them were the same, some of them were new participants. Even in the 5th round, we were still recruiting people who were participating for the first time. So we estimated the population coverage of the program was an 88%. So within a period of 16 months, we offered HIV testing and counseling and all these services in the largest proportion of the population. And another thing that we have seen is that the profile of the participants of this type of program was different from the profile of people who access drug treatment. They were injecting currently, a lot of them were homeless, a lot of them were migrants, and the majority were not linked to opioid agonist treatment. And during the program, we have seen a very large decline in HIV incidence, 78% within this period of 16 months. And we have also seen a change in injecting behavior. Since we had these multiple rounds, we could observe these changes. And also we have seen that people who were repeat participants 2-3 times in the program were linked to antiretroviral treatment and opioid agonist treatment at higher proportion than first-time participants. So we think that the program had an impact in that as well. We used also modeling to see what we would expect if we didn't do that many things. So we think that the program and other intervention at the time resulted in a much lower incidence in 2014 than what we would expect under the counterfactual scenario. And we have also some data about more recent years. So there were people who were tested in 2012 during the outbreak and were also tested in a similar program that we implemented in 2018. That was mainly for hepatitis C, but we also tested also for HIV. So these people who were reached in both periods, we have seen some changes, positive and negative. Positive, that they reduced daily injecting and a larger proportion were currently in opioid agonist treatment. On the negative side, they reported the use of cocaine at higher rates. We have seen an increase in homelessness, and also we have seen a reduced access to free syringes, which is a worrying sign, I think, for an area with a high prevalence and a recent outbreak. I think it's quite worrying. So in this particular subset of people, we have seen an increase in HIV prevalence, 50%, and we have seen also that the incidence, HIV incidence in the recent years, was similar to the levels reached towards the end of the first program. So it didn't increase, but it didn't decrease either. So it's mixed feelings about it. Another good example of how to respond to an HIV outbreak is Glasgow. In Glasgow, and there are people here who could also share their experience. So they redesigned their HIV clinical service model. So they provided HIV services in homeless health facilities. They included outreach nurses. They provided antiretroviral treatment via community pharmacies, which is something that I find very impressive because in Greece we don't do that And that led to a huge reduction in the time to antiretroviral treatment initiation, and also a huge increase in community viral load suppression, which is, I think, it's very impressive as a result. Another example that it's worth looking at is the importance of early identifying cases and rapidly responding. So in a recent paper about the US outbreaks, there is this report that there were a few seroconversions reported in Miami and Western North Carolina. And this, as soon as they have seen these first seroconversions among people who inject drugs, they responded rapidly, they increased outreach, syringe distribution, and they also tried to rapidly link these people to antiretroviral treatment. And you will see that all these 7 seroconversions, within 70 days, they were already they had reached viral suppression, which is very impressive. So it's good to remember that if we respond very early, you could even limit or even prevent, which is the best thing, to prevent an outbreak. So what is next? This seems like a complicated graph from a good collaborator, sociologist Sam Friedman, who works on HIV. So he hypothesized some years ago that big events like wars and population displacement and so on could lead through this rather complex path to increased risk of HIV transmission. So we have experienced one big event, at least one, which is the COVID pandemic, and we know that there were disruptions in HIV prevention services, and we know that access to drugs was not very much affected, and a lot of people in the beginning of the pandemic feared that there would be an impact in the population of people who inject drugs and HIV. Even there was also modeling in New York showing that these potential disruptions would increase the probability of an HIV outbreak. Did these predictions come true? Still, we cannot document, let's say, a cause and effect that the pandemic led to an increase in HIV cases. However, we have reports. In Tijuana, we have a very high HIV incidence. There was a surge in the number of HIV cases in Philadelphia in 2022. And we also have a new outbreak, a second outbreak in Greece in a matter of few years, which is not a very pleasant finding. So in Thessaloniki is the second largest city in Greece. There was a very low prevalence of HIV among people who inject drugs accessing drug treatment programs. But on the other hand, we knew that the access to harm reduction, for example, NSP, coverage of needle and syringe programs, was really very low. In 2016, there was only 1 syringe per person per year. And if you think that there was already an experience of an HIV outbreak in Athens, this seems to be extremely optimistic and very low. I mean, people, perhaps they were not afraid about Thessaloniki. So in 2019, we implemented a similar program in Thessaloniki, but we were not focusing on HIV. It was a program about hepatitis infection. We had included a component for HIV, but we didn't expect to see a lot of people who were HIV infected. Again, we used these multiple RDS rounds. We had a lot of we have a high coverage, despite the fact that during the program we had 2 lockdowns due to the pandemic, which made our lives difficult. And we have seen during the program that HIV prevalence among people who inject drugs increased from less than 1% in 2018 to 3.9 in the beginning of the program and to 9.3 at the end of the program in 2021. Most of these cases were newly diagnosed cases reported for the first time to the surveillance system, and the HIV incidence was 7 new infections. And predictors of HIV seroconversion was again homelessness, that's why I'm saying it's a consistent finding, and receptive syringe sharing. Also in Thessaloniki, we have identified a very high all-cause mortality among people who inject drugs. What was the response in this recent, let's say, outbreaks or surge of cases? In Thessaloniki, there was a scale-up of syringe distribution, and within our program, we tried to link patients to, especially newly diagnosed cases, to HIV care with the peer navigator accompanying patients to the infectious diseases unit, which was really valuable because that period was very challenging. It was impossible to go near a hospital because of the COVID pandemic. And in Philadelphia, they reported a funding of local syringe exchange, fast antiretroviral treatment initiation, and also expanding PrEP, pre-exposure prophylaxis. And I want just to show only very briefly that PrEP, pre-exposure prophylaxis, seems to be effective also for people who inject drugs. reducing the HIV incidence, and a recent modeling paper about the future of HIV transmission in Scott County in Indiana has shown that increasing PrEP coverage would result in averting a large proportion of HIV cases. I know I focused a lot on high-income countries, but the recent outbreaks occurred in these areas. I just want to share a tale of success from a middle-income country in Vietnam, where adopting all these measures that we all know that are very effective resulted in reducing HIV incidence to less than 0.1 new cases per 100% years and ending an epidemic among people who inject drugs. So the lessons learned, I guess the first lesson is that HIV outbreaks can occur and nobody can feel safe, that everything is settled and safe in their own cities or countries. Early detection and rapid response can limit or prevent the development of these outbreaks. Outbreaks can occur even in settings with high harm reduction coverage because there are always people who are not reached, but for sure the outbreak size will be much more limited. Monitor drug injection patterns is essential. We have to remember that often there are low levels of HIV testing, and we should enforce regular testing, including in areas with low HIV prevalence. We shouldn't feel safe that there is no problem in our city. We know that COVID-19 disruptions might have increased the probability of an outbreak, and it's possible that the pandemic might have affected also our ability to identify early an outbreak, because HIV testing was reduced during the pandemic. Homeless people are particularly vulnerable. COVID pandemic had a positive impact because in some cases they were accommodated in hotels and shelters, and this, for example, in Athens, this measure we still have this shelter. On the other hand, there seems to be risks related to homeless people. I have seen this for US and how some cities try to perform encampment sweeps, and this resulted in CDC warning that this could increase the risk of transmission of infectious diseases. So we need to use innovative approaches, in particular in the middle of outbreaks, and I think if I had the money, I would try to combine what we did in Athens with these high coverage interventions and also the clinical, let's say, part implemented in Glasgow. And I think, although I'm an optimistic person, we have a gloomy future. There is a war in Europe, there is an energy crisis. Everybody says that more people will be pushed into food insecurity or extreme poverty, and we are sure that people who inject drugs will be disproportionately affected, and I think we have to take this into account. Thank you.
Thank you. We're going to hold questions at the end. So thank you, Vana. A terrific presentation and incredibly accurate with your timing. So thank you for that as well, and the gloomy predictions. So our next presenter is Becky Metcalf, who's a consultant in sexual health and HIV here in Glasgow with an academic appointment at Glasgow Caledonia University. She has a clinical and academic interest and has published in HIV treatment and care and HIV prevention in people who inject drugs. Thank you.
Thank you so much for inviting me to speak today and for the introduction. I don't have any conflicts. Remember my disclosures, mostly that my better animated slides are done by other people. So I've been tasked today to talk about the recent advances in therapeutic approaches in both prevention and treatment in HIV, with a particular focus on people who inject drugs. And I think in order to do that, we probably need to go back and see how far we've come over the years, or in some cases, maybe how far we haven't come, particularly with regard to people who inject drugs. So back in 1987, we had one medication to treat HIV, and then a few years later, lots and lots of medications, with people having to take lots of tablets every day, not necessarily with the scientific test to let them know whether it's working or not. Move on a few years, and when I started in the field, we had quite a few single tablet regimens with great virological outcomes and very little side effects. And now we're looking at an era where actually injections every couple of months could maintain viral suppression. So treatments are better, drugs are better, but how does that equate to this particular group in terms of people who inject drugs? Well, for a long time, there's been a reluctance to prescribe antiretroviral therapy to people currently using drugs due to fears around drug interactions, perceived or actual poor adherence, and the potential of antiretroviral resistance. And this commentary is actually 15 years old now, but sadly, I think some of the points resonate quite strongly in 2022. The authors note that there's several factors why ART does not have such a good impact in people who use drugs. That delayed initiation to treatment, poor adherence, interruptions in care, and continuing drug use. And there's also social factors such as poverty, social exclusion, discrimination, and discriminatory attitudes from physicians which may contribute to this. And they also noted, and I think some of the talks we've heard in the conference about the success of treatment when we integrate the services, but many years ago they noted that the treatment of drug treatment and bloodborne virus treatment are often structured vertically in separate systems, and that certainly was the way here in Glasgow. This study in 2009 tried to articulate some of the reasons why people who inject drugs may not be receiving ART, and the participants were, as we've just heard Vanna describe, affected by homelessness, involvement in the criminal justice system, incomplete education, poor literacy, and often drug use into childhood. But they did note that ART acceptance and adherence was often associated with regular attendance for opioid substitution therapy, which sounds like a bit of a no-brainer, but remember we've just said that services often structure these things quite differently. So we're not really making it easy for people, are we? So what happens when we do give people who use drugs good access to antiretroviral therapy? Well, again, this is 2009, and this group showed that actually, by improving access, the community HIV viral load coming down, that can predict a lower community HIV incidence, which is completely independent of other behavioural risk factors. And they suggested that we should be implementing strategies to improve access to ART for this population, and then we could have population benefits in terms of reducing the HIV incidence, but obviously individual benefits too. So we've known since 2015 that actually antiretroviral therapy is really good for everybody living with HIV. These three trials showed that there's better clinical outcomes individually, and also actually maybe there's a reduction in transmission with the 052 trial showing a 93% reduction in linked transmissions when viral load was suppressed. Again, what about people who inject drugs? Are they included in that? There's actually no evidence about that the factors that I've just discussed of concerns of adherence or poor linkage into care, that they should be barriers to providing an early antiretroviral treatment in this population. And I've just told you that early ART can actually have good individual benefits and reduce transmission. Well, in the same year as those guidelines came out here in Glasgow, as we've heard, we witnessed a HIV outbreak amongst people who inject drugs, mostly in Glasgow City. This was associated with cocaine, frequent injecting, public injecting, homelessness. And the rise in the HIV prevalence was quite stark, and my colleagues at GCU showed that we were reaching a 10% prevalence in Glasgow City. So the clinicians here were faced with a bit of a problem. And we were led by a very passionate and inspiring clinician, co-chair of today's session, Dr. Peters, who implemented a GECCO, which is an intervention model that Vanna referred to, which implemented an alternative HIV service as opposed to the traditional service that we had in place. Nurse-led, then followed by consultant sessions implemented in the services that these service users use, so in the homeless services or in other places that we could get access to for clinical reviews. Early antiretroviral therapy, and one of the key points was in getting HIV medication dispensed alongside other medications in pharmacies, mostly methadone at the time, but other medications as well. And very glad we used the same slides, but or the same images, because that means they're good. So we showed there that this led to a significant reduction in the median time from HIV diagnosis to antiretroviral therapy. So those who were diagnosed prior to 2016 had much longer wait to start antiretroviral therapy than those after. And the increase in the proportion of patients in the cohort year on year achieving viral suppression grew significantly. But that was in response to a HIV outbreak, so a particular intervention. What if we looked a bit wider than that? The same setting, same services, but what if we looked just outside the outbreak? If we take from 2015, 3 years before, and compare that to the 3 years after, and we compare people who acquired HIV through injecting drug use compared to MSM who acquired HIV through sexual contact. And what we see is that from before 2015, the guidelines changed to afterwards. Yes, in MSM there's an 86% reduction in the time from diagnosis to starting ART, and a 71% reduction in people who inject drugs, which sounds great, doesn't it? But actually the starting point was pretty poor to begin with. And still, despite having the same guidance and the same service, the people who inject drugs, the time from diagnosis to ART was still more than 5 times longer than the time observed for MSM. So, it is achievable, early ART, treatment as prevention, but inequity remains, despite using treatment as prevention as an outbreak intervention. This is in multiply disadvantaged groups, and we need to probably, as we've just heard, we need to change our own models of care and our service delivery to deliver early ART and encourage engagement and retention in care. So what about the newer treatments? Injectable ART, is that going to help us with early antiretroviral therapy and treatment as prevention? I'm going to touch on it very briefly, basically because cabotegravir rilpivirine was approved by the FDA now a year and a half ago, based on 3 trials, 2 comparing the injectables to oral medications, and 1 comparing 1 monthly injections to 2. The 2 monthly is the only one that's available with the EMA license, but there's really very limited real-world data on this. Use is restricted in terms of it's quite a burden on service to actually provide this medication. People really need to have very little in the way of pre-existing viral resistance in HIV, and there is a strict adherence requirement. There's an oral lead-in and then afterwards as well, because one of the drugs got quite a long half-life, so there's been quite a long tail if we don't maintain viral suppression via other means afterwards, which can lead to quite tricky treatment problems in future. Yes, would this be a really good option long-term alongside long-acting opioid substitution therapy? I hope so, but I really don't think we're there yet to think about that on a large scale. So, we know that tackling HIV transmission will need lots of different interventions, especially in people who inject drugs. But what about newer HIV prevention modes such as medication or PrEP, HIV pre-exposure prophylaxis? Well, we've had excellent clinical trial data for a few years now showing that oral PrEP in the form of tenofovir and emtricitabine is effective at reducing HIV transmission via sexual exposure. And we know that that protection was the same for different types of sex. The most important factor is adherence, and the level of protection was very strongly correlated to adherence. So based on these trials, guidelines around the world do suggest offering PrEP to anyone who's at risk of HIV acquisition. But as Vanna has also said, despite all the trials of sexual transmission, there's really only been one that's looked at parental transmission, the Bangkok tenofovir study, comparing oral tenofovir with placebo. And the participants had the option of coming monthly visits or daily observed therapy. And they did show a 49% reduction in HIV acquisition with tenofovir and concluded that it was efficacious as PrEP. The efficacy actually did increase to 73% among participants who chose the directly observed therapy and had adherence that met the author's threshold. Notably, the participants at baseline receiving methadone was very low at only 22%, and the study centres provided bleach for cleaning equipment, condoms, primary medical care and social services all free of charge. So based on that and based on the lots of guidance that we have for sexual transmission and very little for parental transmission, the guidelines around the world do differ slightly. But WHO do recommend PrEP for anyone who's at substantial risk of HIV. So what did that mean here in Glasgow in the midst of an HIV outbreak in 2017 when PrEP became free of charge to those who were at risk via sexual transmission here in Glasgow? Well, we already had experience with GECCO about providing HIV treatment in a slightly different way, so we adapted that in terms of HIV prevention and tried to embed the prevention service also into other services. And the main aim was to provide a service that was acceptable to people who use drugs and encourage engagement and ongoing attendance. We had a very small nurse team who went to find people who we felt, based on WHO guidance, may be eligible for PrEP. So those who are having sexual contact with other people who inject drugs, remembering the prevalence at this time in the city is 10%, those who were exchanging sex for money, accommodation, drugs, or a sexual partner of someone living with HIV who didn't have a suppressed viral load. It was a fluid service, shall we say. So we had an active case finding. We encouraged uptake in PrEP. If someone did take PrEP, there was supervised dispensing at community pharmacies, if that's what they wished. Not everyone did that. Very flexible locations for ongoing monitoring, which guidelines say should happen every 3 months. And the supervised dispensing allowed us to keep an eye on adherence. So we know that's the big concern here that everyone has about giving PrEP to this group. But we were able to, the pharmacies were able to report on adherence, and then the nurses were able to actively follow up people on PrEP to check on adherence or to repeat HIV tests if needed. And that really, I think, is one of the benefits of the pilot study. And we showed after 2 years of the service and 47 people being reviewed that 92% almost had been identified at a service out with sexual health services. So here in Scotland, they're the only people who provide PrEP, so you need to make yourself known to sexual health service, but providing this separate model where the sexual health service went to these other places, 92% were identified through other services. Of those evaluated, 55% were female, which again is completely different to the wider Scottish PrEP cohort, who are overwhelmingly male. There was high levels of injecting drug use in different types of drugs and frequent injecting, and 55% had active hepatitis C, and then they were linked into treatment. There were 32 people who started PrEP over 40 PrEP episodes, which means a period of time where PrEP was prescribed, and it was stopped for a variety of reasons, mainly going into rehabilitation facilities, being incarcerated, or rarely complete disengagement from care, but that was quite rare. Adherence in those PrEP episodes, as reported, was very high, at over 97%. And of the 27 of the PrEP episodes, there was 100% adherence during that time. No one went more than 4 months without an HIV test. The guidance is 3 months regularly, and most importantly, none of those people have since been diagnosed with HIV. So although the Bangkok study did highlight some concerns about adherence of PrEP and PWID, I feel that we're showing that it's very small numbers, but that with high levels of adherence can be achieved with some change in service delivery. But what do this target group want? The people we're saying we're trying to target? Well, actually, some colleagues from GCU did some great qualitative work looking at that, and it showed that actually here in Glasgow, the people interviewed, there was a willingness for PrEP, but there were definitely some barriers to engagement. Poor levels of health literacy, or their own understanding of their own risk of HIV acquisition, which, remember, can change from week to week, was a barrier. They wished PrEP to be promoted in a way that is relevant to them and at a time when they were most open to health messaging, which again isn't all the time. They also wanted a service which was provided within the existing services that they already attend, which hopefully is something we tried to achieve through our pilot. And this is your daily reminder that although PrEP is brilliant, I think it's brilliant, its combination prevention is really important in all groups, and especially in people who inject drugs. We need good HIV testing programs, needle exchange services, and a comprehensive ART program to match, because it won't work by itself. So what about the future of PrEP? Well, there's been quite a lot in terms of drug development for PrEP in the last 10 years or so. And two in particular that I just wanted to mention. Obviously, we talked a lot about oral PrEP there, but we do have, this is a vaginal ring, dapivirine ring, which was evaluated in the HOPE study, and showed that when adherence was high, again, adherence is key, this monthly ring that can be self-inserted results in a 39% reduction in HIV acquisition. Obviously, that is lower than the studies of the oral PrEP, but the advantage of this method is very discreet, long-lasting. It means that relationship sex partners or sex partners for sex or drug or for money or accommodation, or people who are living in shared accommodation or maybe don't have any accommodation, no one else needs to know that there's PrEP, even they don't have to carry around a bottle of PrEP. There could be some real advantages here for women and trans men, and WHO do recommend it for women at high risk of HIV as part of combination prevention. The big discussions have obviously been around injectable PrEP, and these are the two trials who have both shown superiority over oral PrEP. HBTN 083 being the big, some of my graphics haven't come across unfortunately, but being the study that was carried out with adult men and transgender women, and showed a 66% reduction in the cabotegravir arm, injectable cabotegravir, compared to the oral PrEP. And we know oral PrEP works really well, so that is significant, with a very low incidence of only 0.4 per 100 person years in the cabotegravir arm. Similarly, in the 084 trial, which was focused on young women and girls, a very, very low incidence of 0.2 per 100 person years in the cabotegravir arm, which is really impressive, given we know the control arm of oral tenofovir and emtricitabine works very well too. Both those studies were stopped early due to superiority, with everyone being offered injectable cabotegravir. This could get around the need for daily adherence to pills and all of the things I've talked about in terms of people taking own control and not other people not having to know that they're on PrEP. What we're seeing is an injectable option, which is long-acting. It may be a really good option for many people, and especially people who use drugs. And it was approved by the FDA in January of this year. The EMA license is awaited, but it could be a really exciting option to use long-acting opioid substitution therapy, and maybe a chance to provide a really holistic model of care, and something that I would certainly like to try out here in Glasgow, if I'm able to. So that sounds great, but there's obviously challenges, and these challenges will be the same as we've discussed throughout this conference. Retention and care here in Glasgow, and I mean, Erica Peters is got a lot of credit to take for this. We've been passionately and persistently pushing the HIV treatment service in this group, which has led to very high levels of retention and care, showing that we're working closely with other services who may not even be in the same sector as you. We can achieve that and all the benefits of that. But education is also really key, especially about HIV prevention. So educating people about what HIV is and their personal own risk, but also the services that they work in, so that they can then provide information to people about the rights that they have to access HIV prevention treatment and helping them to get it. And of course, we're all in a world where there's no money, and individuals with very, very little money to even buy food are going to find it really difficult to get to a service across the other side of the city. We're all in services where we're told there's no money all the time, and constantly having to fight for adequate resource just to do the day job, never mind trying to put an additional service on top of that, is really hard work. And advocating for this group within a very complex healthcare system is very hard work as well. So thank you. A lot of people have contributed to the clinical and academic part of this work in Glasgow. So thank you very much to them, and thank you for listening on this Friday afternoon. Hope you enjoyed Glasgow.
Thanks, Becky. I am very passionate about this work, but I think you must all be passionate as well, because you're staying to the very last bit of the conference here, so well done. Our final speaker today is Professor Brandon Marshall, who's going to, Brandon's come all the way from the States here to speak to us today. Sorry, Brandon, I'm just trying to get your bio up here. Apologies for that. It's just flipped off my phone. But Brandon has been doing a lot of work, including with the HIV outbreaks in the US, and has also been doing some modelling work as well. And I think you're going to give us an update on all of that. Thank you, Brandon.
Thank you so much. So I have the unenviable position of being the last speaker in the last session of the last day of the conference. So thank you for sticking with us. I'm going to talk about where we are in terms of sustaining and ideally eliminating HIV transmission among people who inject drugs, drawing off the two previous phenomenal presentations. I forgot my disclosure slide, but I have no disclosures to declare beyond receiving funding from the National Institutes of Health in the US. So you might be tempted to say that we are actually in pretty good shape when it comes to HIV prevention for people who inject drugs and other at-risk populations around the world, because the last 2 decades have been marked by increasing numbers of highly efficacious HIV prevention modalities. We've heard from Vanya that antiretroviral therapy as prevention works. We've heard from Rebecca that pre-exposure prophylaxis, or PrEP, for HIV prevention works. And we know from decades of experience that harm reduction interventions like syringe service programs work. And we know that when these interventions are delivered in combination and at scale, we can see significant reductions in HIV incidence and HIV prevalence in essentially every context in which they're implemented. And there have been some successes because of these interventions. The UNAIDS report that came out recently suggests that we've seen about a 23% decrease in new HIV diagnoses over the last decade overall. However, there is no evidence of changing HIV incidence among people who inject drugs. And in many settings, we're seeing increasing HIV incidence in this population. Moreover, the overall proportion of new HIV infections attributable to injection drug use has remained stable at around 10% for the better part of the last decade. And finally, although some countries have seen dramatic success at drastically reducing the number of new HIV diagnoses among people who inject drugs, globally less than 1% of people who inject drugs have access to life-saving harm reduction, treatment, and HIV prevention modalities. So why is this? Why do we have so many tools in the toolbox and yet so few people around the world being able to access these interventions? Well, we know that the criminalization of drug use and harsh penalties for possession, like incarceration, push people away from services, they discourage use of those services, and they delay or prevent the implementation of these programs altogether in many settings. And we have strong evidence that policies that decriminalize possession and other interventions that address the tremendous stigma, discrimination, and marginalization that people who inject drugs face on a daily basis in most countries can dramatically reduce HIV incidence, prevalence, and HIV-related deaths. But we know that implementation of these policies matter. We had some tremendous evidence presented this morning from Natasha Martin in the plenary, whose team evaluated the impacts of drug decriminalization policy in Mexico, which decriminalized possession at small thresholds in 2009. Unfortunately, what they found is that these policies probably had low or no effect on preventing HIV infections among people who inject drugs in Tijuana in the Baja state, because these policies were linked with mandatory compulsory treatment after 3 apprehensions for possession above the thresholds. And in many cases, these treatment programs are abstinence-based, provide non-evidence therapies, and are essentially functioning as prisons. And what they found was that that policy, as implemented, probably caused harm. It probably increased HIV transmission, which is shown on this third box plot here. In contrast, what they found is if a policy had been implemented that eliminated syringe confiscation, reduced incarceration among people who inject drugs, and provided increased access to opioid agonist therapy in this setting, we might have seen a more than 20% reduction in HIV incidence over the 12-year simulated time period. This is a more recent mathematical modeling study from researchers in UK who simulated HIV transmission in 4 settings: Belarus, Kyrgyzstan, Kazakhstan, and in St. Petersburg, Russia. They found that policies in which drug possession was decriminalized might result in small reductions in HIV incidence in some of these settings. But importantly, what they found was that by reallocating resources that are saved as a result of reducing incarceration in this population and by reallocating those funds to a public health approach that involves scaling up harm reduction, antiretroviral therapy, and access to other HIV prevention tools, you could see significant reductions in HIV incidence in all 4 of those settings, which is shown by the red and yellow bars. So I want to talk a little bit now about the situation in the United States where I live, and I'm sorry to report that the situation is pretty abysmal. We have seen increases in new HIV diagnoses over the last several years among both men and women in the US, and stable or increasing HIV diagnosis rates in pretty much all racial ethnic subgroups. We've also seen substantial outbreaks of HIV in the United States, which Vanya talked about. One of the first and largest that was observed ever in a rural setting was in Scott County, Indiana, in which more than 180 people were diagnosed with HIV over a 1-year time period in a very small rural population of just under 24,000 people. There was an extensive outbreak investigation led by the health department and supported by the Centers for Disease Control and Prevention. And they found that significant socioeconomic marginalization, housing instability, and the frequent injection of extended release oxymorphone, otherwise known as Opana, probably led to the rapid transmission of HIV in this setting. Just north of where I live in the state of Massachusetts, we are contending with significant HIV outbreaks in suburban settings in towns of Lowell and Lawrence in 2017, 2018, and we are experiencing an ongoing HIV outbreak in the city of Boston, even in a setting in which harm reduction coverage is decently high. So these are major problems in the United States and in other higher income countries. I want to talk a little bit about some work we've done trying to understand what could have happened in Scott County, Indiana, if harm reduction services had been present before this outbreak really took off. So I want to take you back to Scott County, Indiana. This is in the south part of the state, which is located in the Midwestern United States. As I mentioned, it's a very rural setting, very low population density, almost entirely white non-Hispanic residents, and a very high level of extreme poverty, poor housing conditions, and extreme socioeconomic marginalization as well. This is data from the Scott County Health Department that shows the number of prevalent HIV infections that are known in the county over the last decade or so. You can see the impact of that outbreak very dramatically in 2015. The subsequent contact tracing and outbreak investigation that took place in Scott County also identified an extraordinarily dense sexual and injecting network. People had many partners. Because of a complete lack of harm reduction services entirely, people were forced to use and reuse syringes over and over, which rapidly perpetuated HIV transmission through this dense network. And we were able to use this rich information to parameterize some mathematical models, which I'll show you the results from in just a moment. Eventually, syringe service programs were implemented in Scott County after a state of emergency was declared by then Governor Mike Pence in late 2015. Unfortunately, genetic evidence suggested that most of the transmission of HIV had already occurred by the time that syringe service program was implemented. The blue cloud and the black bar show you the estimated time of HIV seroconversions in the population, and the red line shows you cumulative diagnoses that were identified by the health department sometime later. So we were interested in asking the question, well, what if this horrible situation had been different? What if people had actually had access to harm reduction programs, HIV screening and testing and treatment, and also access to evidence-based opioid agonist therapy as or before this outbreak was taking off? So that was the question we sought to answer with some simulation approaches. So to do this, we used an agent-based model that my team at Brown has developed. We call this model Titan. The model is an individual-based microsimulation. It consists of agents who represent people interacting with each other in a dynamic sexual and injecting network. So by dynamic, I mean that over the course of the simulation, people can change their sexual partners or injecting relationships. The model is a discrete time model, so each time step represents a month of time in which we record new HIV transmissions occurring, and then we compare HIV incidents under different rule sets, which represent different policy scenarios that might have been in place and which we're interested in looking at. So as I mentioned, we used data from the outbreak investigation that occurred in Scott County to simulate the networks that were present and the transmission of HIV through these networks over time. And in order to try to represent an outbreak, we seeded the model with a single HIV infection at the beginning of the simulation and let it essentially go over a 5-year simulated time period to see what impacts and policy changes might have had in this setting. So this is kind of a schematic of how this works computationally. We start with a single HIV infection, which is denoted in red. This is a stable network for the purpose of visualization. And over time, month over month, HIV is transmitted through this network as shown. Okay, so we also assumed a prevalence of about 1.7% of injection drug use in the model, representing about 400 people out of a population of 24,000. We also assumed that 55% of the population would enroll in a harm reduction program if it were implemented based on what actually happened after that state of emergency was declared. And we also assumed that among people who were engaged in a syringe service program, syringe sharing was very unlikely and therefore HIV transmission very rare. I just wanted to show you the current state of harm reduction services in Indiana. This was pulled from their health department last week. Unfortunately, there are really very few counties in which harm reduction programs are currently operating. That's shown in yellow. And in fact, there are more than 10 states in the US in which there are no syringe service programs operating at all. So when we talk about low coverage, we mean effectively no coverage of harm reduction in many US contexts today. So I'm going to walk you through 3 modeling scenarios. The first is if a syringe service program had never been implemented throughout the course of the outbreak. The second scenario is a rapid response. If we were able to rapidly scale up HIV screening, linkage to care, and implementation of harm reduction services shortly after an outbreak is identified. We used an arbitrary threshold of 10 diagnoses to start that scale up. And then the final scenario was a proactive scenario in which harm reduction services and HIV case finding and treatment had been available the whole time throughout the course of the simulation. So this is a stochastic model, which means we have to run the simulation many times. Each individual run across 1,000 iterations is shown by a purple line here, and the average over 1,000 runs is shown by the black line over a 5-year simulated time period. So what we can see here is in the absence of harm reduction services, HIV outbreaks usually take off to the point of observing potentially hundreds of new HIV infections in the population over the course of the simulation. If we intervene quickly, we're able to put a lid essentially on that outbreak and reduce the likelihood of it taking off in the population. Overall, we saw a 60% reduction in HIV incidence if a harm reduction program were implemented after 10 HIV infections were diagnosed. And these are the results from the proactive model in which syringe service programs had been existing in the county the whole time. We saw in many situations no outbreak occurring at all, and overall average HIV incidence being reduced by more than 90%. This shows you, at least in a hypothetical mathematical model world, that harm reduction programs are prevention, right? They prevent HIV outbreaks from starting in the first place. This is another way to view the data, just looking at the distribution of outcomes across the 3 scenarios we examined. So this is HIV incidence, and then the density of each 1,000 model run for each of the 3 scenarios. So it's just another way to show you that if a syringe service program had been present in Scott County, the likelihood of HIV incidence coming above, say 10 per 1,000 person years is really very low compared to situations in which harm reduction services are not available. In a more recent paper, we looked at what might happen if syringe service programs close in a high prevalence setting. This is a reality in the United States. Due to political opposition and lack of funding, harm reduction programs are closing or are having their funding taken away by local and state and county governments. So we were interested in looking at this, what might happen if a syringe service program were to permanently close, whether it were to close after some period of time of operation, or whether it were to close for 1 year, sort of representing an interruption in services due to COVID, for example. So we ran this model for 10 years, I think. This shows you cumulative HIV prevalence at the end of the situation. A syringe service program operating the whole time results in very little change in HIV prevalence from the beginning of the simulation, which is shown in the dashed line. Closing an SSP, as won't surprise you, increases the likelihood of ongoing transmission and subsequent increase in cumulative HIV prevalence by the end of the simulation. And even delayed and temporary closure of a program can increase the risk of rebound outbreaks in a high prevalence setting. When we ran this model in a low HIV prevalence setting, the impacts were actually larger because of a greater number of people susceptible to HIV in a lower prevalence setting. And finally, as was mentioned by Vanya, this paper just came out the other day in JADES. We looked at the potential impact of scaling up access to PrEP among people who inject drugs in Scott County, Indiana. We ran 2 scenarios here, one in which PrEP was given exclusively to people who were already engaged in the syringe service program, and a second scenario shown in blue in which PrEP was available to all people who were injecting drugs regardless of whether they were currently engaged in an SSP. And then we scaled up coverage for PrEP from 0 to 70% of the population in both of those scenarios. And what we found was that scaling up PrEP exclusively to people who were already attending harm reduction programs unfortunately didn't seem to have a significant impact on average HIV transmission. And that's because these people are already accessing harm reduction services and are benefiting from those preventive resources. In contrast, we saw much more significant gains and reductions in HIV incidence if PrEP is made available more broadly, independent of someone's current access to other harm reduction programs. So just to sum up here before we get to the Q&A, we have the public health tools to sustain and I would argue eliminate HIV transmission among people who inject drugs, but they have to be brought to scale, right? Scale is critical here, especially globally. And as Becky mentioned, combination approaches are really going to get us there, and they need to engage people who are not currently accessing harm reduction programs. We need to be more innovative, we need to be more creative at engaging with folks who are not already linked into some kind of harm reduction practice or care. And finally, I would argue all of this is predicated on fundamentally changing the way in which we criminalize drug use, the way in which we create more structurally supportive environments for people like housing and funding for sustainable harm reduction resources, and other policy changes, like in the US addressing the effects of systematic and structural racism that's so pervasive in our healthcare, treatment, and carceral systems. So that's what's going to be needed, in my view, to get us to our goals. With that, I want to finish and acknowledge all the wonderful students and programmers and collaborators who have helped make this work possible, and the funding from the National Institutes of Health. And feel free to contact me afterwards by email, and there's our team's Twitter account as well. Thank you so much.
Another fantastic presentation. I just don't know how people manage to get precisely to time that this way. So I'll ask all three presenters to come and have a sit up on the panel if we can. Just a reminder that anybody that's online, if you can enter questions and they'll appear on this tablet in front of us. There's two microphones in the middle of the room, so if you're in front of the aisle, you'll need to walk backwards. Yes, so start
Hi,
the question.
I'm Stina Hoy from the University of Montreal. Thank you very much for your presentations. I have a question about the implication of changing drug trends in HIV outbreaks, because it seems that there's no real consistency in the types of substances that are becoming more common. And at the moment in Montreal, we're seeing we haven't historically had much methamphetamine injecting. It's really been increasing over the past decade. So I'm wondering what you think is implicated in that. Is it that harm reduction isn't adequately adapted? Is it that people are injecting in new networks, or new people are coming into the injecting group? I'm just interested on your thoughts.
I don't know who wants to take that. Brandon, maybe you know the background.
Sure. You know, I find it so complicated to predict at this point where we're going to go with such a toxic and deadly unregulated drug supply, particularly in North America. And I don't see a way of getting out of it until we address the fundamental cause, in my view, which is the fact that it is unregulated. And so until that point, I feel we're going to be chasing our tail, constantly trying to address the emerging harms from these novel substances. Right now, for example, in the Northeast, in the United States, we have a major issue with xylazine, which is an animal tranquilizer, which is causing abscesses, subcutaneous injection-related infections, and other infectious sequelae that previously had been more rare. And so trying to identify that and address that clinically and from a public health approach is always feeling like we're 2 steps behind where we would need to be to finally get ahead of some of these rapidly evolving changes in the supply. So it's extraordinarily challenging and a testament, I think, to the harm reduction programs out there doing that work to try to keep us on our toes and as best we can address the problem in real time. Yeah.
I think Andy, who's about to ask the next question behind you, knows a lot about this as well, but it's certainly one of the concerns we have, and was highlighted that the cocaine use in Glasgow requires people to inject, or people inject multiple times, whereas the historical heroin usage, it was possibly once a day in this particular population. And we know that that's an issue, and we do struggle with that because we don't know what the right thing is. I mean, I'm not addiction-trained doctors. There's plenty of people in the room, I'm sure, are more expert in this, but essentially we don't have a substitute for these types of drugs, and it is a challenge. And I think some of us were discussing consumption rooms the other day in a meeting, and I guess one of my questions was in people that have experience of consumption rooms, if people are injecting multiple times a day, are they going to essentially hang out in a consumption room for the whole time? And what impact will that have on these on this particular issue? I appreciate there's lots of benefits from a consumption room, but I think it's a really challenging question, actually.
Hi, I'm Andrew McCauley. I work in Glasgow and I really enjoyed the session. I think congratulations to the speakers, but also to whoever put together the session, because she's really complemented each other really well, and I feel as if I learned a lot over the last hour or so. I actually had a similar question, but I had 2 questions, so I'll ask my second one. But I do think we do have the toolkit, Brandon, but I think the toolkit has been undermined by this shift to stimulants, because I think people who traditionally would be using opioids moving to stimulants, and their compliance with things like OAT is inherently affected by that kind of change in behaviours. And I think we don't, as Erica says, I don't think we've addressed that well enough yet, because we don't have the treatment options. But anyway, that's just my 2 pence worth on that. My question was a follow-on actually from a session we had yesterday on biobehavioural surveys of people who inject drugs. And what we were trying to do was really to advocate and promote more use of those. Obviously they have value for a research and evaluation purpose, but what we've seen during the course of the Glasgow outbreak is that they've had real value as a public health tool. First of all, to quantify the size and scale of the outbreak, as you've seen in Becky's slides, but also eventually to start as a kind of early warning sign of hotspot areas and other places. And it's noticeable in a lot of the areas, as Vanna's saying, we have this kind of fire moving out, there's more and more outbreaks. But a lot of the things that characterise these areas is a lack of routine surveillance or biobehavioural surveys in these areas that might act as an early warning. And I just wondered what the panel thought about the value of those kind of things and how we might use them better moving forward.
Well, thank you. And first of all, I have to make a note about, for example, the recent outbreak in Thessaloniki. If we didn't perform this particular program, we wouldn't have realized that there is an outbreak. Looking at the HIV surveillance data in Greece, and HIV surveillance data in Greece are good, because if you want to get treatment for free, first of all, everybody reports new HIV diagnosis to this system, so it's quite good. On the other hand, HIV testing during the pandemic reduced a lot. So looking only at routine surveillance data, everything was great in Thessaloniki, no problem at all. So only through these biobehavioral surveys and testing, repeated testing, often testing during the program, allowed us to observe seroconversions, not just newly diagnosed cases. And I think especially in areas where the number of HIV infections is low. For example, Thessaloniki has a low population size of people who inject drugs. I think it would take us a long time to identify the outbreak. And I've seen also in Glasgow, although phylogenetic analysis shows that the outbreak had started some years later, perhaps a small number of cases didn't allow you to observe the outbreak. I think it's necessary to do it. At least in our case, it allowed us to monitor changes in behaviors, and so also when you do this repeatedly and you see people repeatedly, it's good because you increase coverage, linkage to care, everything. It even helped us to estimate mortality over time, to estimate incidence, to estimate indicators that are necessary but are very difficult to estimate otherwise.
Yeah, that's a great point, and I would add, that I think these kinds of biosurveillance programs are critical, and also ways to listen to people who use drugs as well. In Providence and Rhode Island, we have ongoing ethnographic work and continual survey assessments to understand what people are seeing, and that information is then reported back to the health department in almost real time. There was a homeless shelter, a pop-up homeless shelter that opened last winter in Providence, and we were hearing reports of a lot of ongoing overdose risk and HIV-related risk. The health department was able to work with harm reduction organizations to engage with those folks, conduct HIV screening, hepatitis C screening. They identified 2 previously undiagnosed people and linked them both to care and provide harm reduction services, naloxone, to other folks living in the shelter. And those kinds of programs, could potentially prevent a significant outbreak like we're seeing in other places just up the road in Massachusetts. And only from understanding and listening to people who are actively using and have that information come back to the health department and to other harm reduction organizations are you able to take action quickly. So I think those open flows of communication between various stakeholders is absolutely critical too. So thank you for that question.
One more question at the microphone and then 2 more online.
Sure, and it's a little muddled question, but for Brandon, and everyone's presentation was amazing, but Brandon in particular, towards the end of your presentation, it felt, my eyes sort of perked up when you were talking about the impact of engaging people at SSPs and PrEP versus expanding SSPs just across the board. And I was just thinking, in the States with constrained resources and really constrained political capital, I'm wondering if you think that the data, can we be using your data? Should we be using your data and things like it to really put more of our eggs in the basket of expanding SSP rather than other things like PrEP or drug consumption rooms? Or so how do you think that they relate?
Great. I think it's got to be a yes and all of the above at this, given the state of these multiple overlapping syndemics and crises, it has to be a yes and approach. The findings that we had were surprised us, that focusing PrEP exclusively among people who are already engaged with SSPs did not seem to have the public health impact. And that is where we're seeing a lot of emphasis, I think, right now on PrEP being delivered. But we have to do better. We have to reach people who are not engaged in harm reduction services, people who are pregnant or women whose partner might be engaged in harm reduction services, but they themselves are not. Folks like that could benefit from PrEP, for example. So we need a whole bunch of innovative strategies, I think, to be more inclusive in our biomedical HIV prevention strategies to complement the effective harm reduction approach. Yeah, so it's both, yes and, yeah, ideally.
So is a question or a comment, I suppose, on the app as well, and this is from Nicholas Baldwin. Brandon, is there actually more funding and political acceptance for PrEP compared to syringe distribution programs for people who inject drugs in the US? It's baffling that such a simple, cost-effective and evidence-based practice as syringe distribution can be achieved. So I think it's, yeah.
So I think one of the key challenges actually to increasing scale-up of PrEP among people who inject drugs is the tremendous stigma and misconceptions that were addressed, I think, in your wonderful talk, Becky, about these folks won't adhere, they won't come back, they won't, come back for HIV testing. And you're showing that that's not true and that people want these HIV prevention modalities and that they work. And so cost aside, I think it's a lot of the misconceptions and stigma even within the healthcare community that prevents a broader scale up of some of these interventions. And then, like everything in the US, PrEP is outrageously expensive in the absence of health insurance. So that's a major issue. Less so in Massachusetts and Rhode Island, where we've achieved almost universal healthcare coverage. But in other settings in the US, certainly that have not expanded Medicaid, cost would be a functionally significant barrier to expanding access to PrEP for anyone, never mind people who inject drugs.
Another question or comment online from Anadi Akpan. In Nigeria, people injecting pharmaceuticals have a higher frequency of daily injecting than people injecting heroin. The WHO recommended 27 needles and syringes per month is not sufficient. Is there a need to differentiate needle and syringe program distribution, at least for pharmaceuticals and other drugs? I'm asking because as a project implementer, pegged needles of numbers and syringes they give to distribution. This seems to make needle and syringe programs ineffective in preventing HIV because of repeat needle use and sharing. So it's back to the question about synthetics.
Yes, I think it's important to know, to have some data about injection frequency in your population. Otherwise, if you have just, and even if you think that today you are covering the population, perhaps in 1 year's time you're not covering their needs. And in general, I'm a bit skeptical about all these thresholds, 300 syringes per year or whatever, because there are people who take 500 and other people who take none. So it's important to monitor the substances used and the frequency of injecting, how many times per day, and to adjust, I think, your programs to this.
I'm not an expert in this, but I know that is what happens in Glasgow, and I think sometimes there can be a perception that that's a bit inquisitive, asking lots of detailed questions about exactly what's being injected, but that allows then the programme to give the right number and type of equipment, and yeah, that's what happens here.
Can I ask a question of the Glaswegians about their experience of retention on ART and retention on PrEP over the long term, particularly retention in PrEP in all PrEP programs, irrespective of the target, and discontinuations becoming a real issue.
Becky can do the PrEP and I can do the ART. we have really good retention in care, and we achieve viral loads and detected levels similar to our other population that are coming to our clinics. So the only way we can do that, though, and the thing I guess that we haven't really talked about today as much is, it's all this about health inequalities and how you design something to make sure that you do get these equal outcomes in populations. And the big thing that we need to do with that is have a really robust staffing, and that is the thing that we struggle with. It's one of the big things that I have advocated for, because in order to make sure these people do engage in care and attend services is that we need a lot more nursing care than we do for somebody that comes twice a year to get their kind of once over check in the clinic with me, in between going to work or whatever. So I think that is something that we've talked about a few different things that we do, but having our nurses on the street, literally going to find people and making all the links with all the other, we work with third sector organisations as well, to have that information sharing and gathering is something that takes a lot of time and a lot of staffing cost, which is a struggle.
Yeah, and the other thing I think that we do quite well in both is a very open, non-punitive approach, if you like, and I think we hear that echoed, that obviously that people don't engage with that process, but certainly our nurses who deliver the HIV treatment, it's very much building up a rapport and a relationship, and yes, it might take them 10 attempts to find that person, but they're really excellent clinicians, and they never take a punitive approach to that, which really helps with engagement. PrEP's interesting, so I obviously focused today particularly on people who inject drugs, and it is a different model that we've adapted. Actually, to be honest, right now our retention in care in that particular group is quite low. However, we have had loads of contacts on PrEP education, and the uptake has been quite low recently. And we hope to look at that in coming months. I don't know why. Is that because actually there's less talk about it because our number of new diagnoses has gone down? I don't know, but actually just in the last month, the number of people who've had contact with our nurse team, the sexual health and HIV outreach team, and had the discussion about PrEP has been higher than ever, but we've had very few new starts. In terms of the wider PrEP provision in Scotland, it's completely different, actually. The numbers are increasing, and PrEP's completely free at the point of access in Scotland, but only available through specialist sexual health services. So that is putting a lot of pressure on services, and actually we're having to look at changing our services the other way, a less resource-intensive model. So, here in Glasgow, we didn't stop our PrEP provision all the way through COVID, and the number of people now on a sort of long-term PrEP is record high, and that's putting pressure on services in the same way as Erica described. We need to have the staff to deliver those services. So in order to maintain retention and care, we've actually started giving out longer prescriptions, so 6-month prescriptions, the guidelines say 3, and then just asking the person to come back for a very kind of low consultation clinic appointment just to get bloods at 3 months. And my colleagues are working on that now, but we've shown actually that's worked really well. So rather than create a waiting list or stop people accessing PrEP, we're just having to change our services in a different way. And I think that's part of our role. That's really important as specialists in HIV prevention, that we divert the resource to the right place. So if we want to try and get the people who aren't accessing our services, then that's where the resource should go. And the people who are accessing it very well and will come for appointments, look at something slightly less resource intensive for them. That's what we're trying to do.
If the others wanted to comment on that. Some more questions?
I just wanted to... Oh, sorry, on you go.
No, go ahead,
please. Please, you go first.
I need a little extra time to think of my question. Hi, I'm Alex Wally from Boston, Massachusetts in the US. So the discussion around PrEP, both in the last 2 presentations, was really interesting to me. So I'm a HIV primary care doctor. So I don't actually treat people who don't have HIV, but I've been thinking about PrEP for a long time, and work with people who are at risk for HIV. And it's been really hard to get uptake in our environment, which does have access to harm reduction and medication for opioid use disorder. But I am in that place that Brandon mentioned where there's an ongoing HIV outbreak. And so that really twists the mind, because you showed data from Indiana, and the explanation there was just that, well, there was no medication for opioid use disorder, there was no harm reduction, and so how can it be that where there is, we're having these HIV outbreaks, which it sounds like a little bit what Glasgow has been also experiencing. And so, when there's an HIV outbreak in the face of harm reduction and medication treatment, that's a place where you really need to think about PrEP, because we need to bring all things to bear. Then you start looking at the particular populations, which I think is what you did in Glasgow, and it's what we're trying to do in Boston, and really focus the efforts in the micro group of people that are transmitting the virus. And what we've seen in that setting, when I work in the hospital, I actually have seen people coming into the hospital who are taking PrEP, who are people who inject drugs for the first time in the last year or two, in the midst of this outbreak, which has been really good news. And that's because of very strong and active work by outreach nurses who are, basically following people around. Now, that's bringing it to them, but it's also salient to those people. So when I've talked to people in the past about PrEP who were injected drugs, they just don't see the point. Like they aren't seeing that many HIV infections among their cohort, and it just doesn't seem practical for them to come into the hospital or come into the clinic. So the setting, I think, where it gets more severe, that can drive the saliency for PrEP, not just for the individuals who need the PrEP, but also for the healthcare system. And so now that I've seen people take it successfully as a healthcare provider, I'm much more open to PrEP as an option. And so while the way Brandon sort of set up that, I think it doesn't surprise me that PrEP on top of a saturated SSP environment or needle syringe program environment doesn't add that much. I think we got to start somewhere in order to get this to be salient to people who inject drugs and also the providers that are going to offer it. And then we need to go beyond, because I'm not sure how it is in other countries, but even where we have harm reduction, there are still people who don't take advantage of harm reduction. We have a lot of hidden populations that are still marginalized, even from our outreach services. And so we have to sort of constantly be adapting our outreach services in order to adapt to those populations. So this isn't a question, it's more of a comment and just like me spewing my thoughts. One other thing that was stimulating, and I have seen, which is the long-acting, we do have cabotegravir, rilpivirine in our clinic, and we are using it with people who inject drugs who have HIV, and it works. It's fantastic. You need buy-in. So this makes me think of the previous presentation this week on medication for opioid use disorder, where the focus was on choice. And I think we need to bring that choice paradigm that they were advocating for medications into harm reduction. So, it's not just about us persuading people to take PrEP, but really asking them what they want, when they want it, and give it to them. And that goes along with the injectables. So not everybody's going to want an injectable.
2.5 minutes left in the presentation, and one more question.
Thank you very much.
Well, thank you. I think really good points there, and actually I didn't quite read out my summary slide, but that's one of the things that I think in treatment and prevention is, if we're going to get to HIV transmission elimination, we have to have a choice of method and delivery, but that has to be available for everyone, not just people who can come and advocate for themselves.
Probably the last question is that.
Hi, I'm David Perlman, infectious disease physician and researcher from New York. And so New York's an area where we have a lot of access to PrEP, and a lot of pretty reasonable access to syringe service programs, but they're really entirely siloed. I mean, the PrEP is entirely among MSM, or almost entirely. And of course, the syringe services are really entirely among injectors. So first, I think a lot of the metrics that look at coverage by a geographic jurisdiction must miss some of the point, because it tells you what's in that area, not who has it. I mean, and there are old good data about combined prevention in cities, where when cities have both syringe services, antiretroviral therapy, HIV rates go down, but that's not disaggregated by population. So I guess, Brandon, your data is really important. I guess one thing that I don't know, maybe if someone knows data, are there data showing that there's an advantage to adding PrEP to individuals or populations of injectors who are well engaged in syringe exchange? Is there additive benefit, at an individual or population level? Mm-hmm. And I guess the other sort of maybe thought question, it relates to the fact that they're so both poorly implemented for people who use drugs, but the barriers are a little different. And I guess sort of paralleling a question someone asked, for regions that where it's harder to open syringe service programs, could there be greater emphasis placed on PrEP for injectors, where in some, it's medicalized, which has bad aspects, but other ways that make it more sellable to policymakers? So could some of the strategy be more focused to what the barriers are? So there's a couple of questions and thoughts scrambled together.
Yeah, I'll take the first one. That's what this modeling study is trying to do, is encourage us to think about what is that added benefit of layering PrEP onto SSPs. I think I'm aware of studies that are ongoing to evaluate that impact at the individual and population level, and there are specific groups who may benefit more than others, people who are injecting and also engaging in sex work, or queer folks who are also injecting drugs who would benefit from the layered protection. So that's, I think, where we need to go in this discussion, is drill down a little bit more detail and look at the overlap as you're describing, rather than work in that siloed approach, is such a good point. Yeah. And I'll let maybe one of my other presenters take if you have a response to the second question about PrEP in more adverse contexts versus SSPs.
I don't know. I mean, I think that everybody who is at risk of HIV should have access to PrEP, but as we've kind of clearly highlighted, that's going to differ between provision and countries and how they do that. I think it has to be combination prevention, because there's other harms as well. It's not just HIV. So if you give PrEP to everybody without SSP, then I'm not sure you're going to completely reduce the harms. But
yeah, as a person that treats lots of skin and soft tissue infection and deep-seated infection, there's a lot of other harms that could be at least somewhat alleviated by needle and syringe programs as well. I'm going to draw this session to a close. I'd like to congratulate the speakers on a fantastic session. You really, I think, pulled it all together, and it was really, really helpful. And the discussion from the audience was really helpful as well. I think this is a discussion that we're going to maybe all take online, I think, and onto Twitter and onto our social media and by email and things going forward. I'd just like to say, from a local perspective, it's been wonderful to have all the delegates here in Glasgow and let you see our city. And as Becky said, it's people that make Glasgow. We have some nice buildings, but the people that we work with in Glasgow, colleagues and patients alike, are what make Glasgow. So I hope you have a safe journey back, and thank you very much for attending the very last session of the symposium.